Hello everybody, I am Dr. Sarita Ravindran, an ophthalmology resident. We are going to be seeing about field changes in glaucoma that can be diagnosed using the perimetry. So the objectives of our session would be to describe field changes in glaucoma, to demonstrate how to interpret visual field changes, to discuss the indices, to consider when assessing progression, to list newer types of perimetry for glaucoma. So what exactly is perimetry? It is the measurement of visual functions of the eye at topographically defined loci in the visual field, where each eye is tested separately. Actually, all of this will make more sense as we proceed throughout the presentation. So let's get into it. So here I said that each eye can be tested separately, but your examiners might ask, where do you do a binocular testing? So in very advanced stages of glaucoma, we'll do binocular testing. It's a test called the Esterman's binocular test that is available on Humphrey's visual field. Humphrey's visual field is what we use right now in almost all of the hospitals. So what exactly is a visual field? So a visual field is defined as that part of the environment that is visible to the steadily fixing eye. When you're fixing at a specific point, whichever area can be seen by the eye while fixing on that same point, that is what we call as the visual field. So the boundaries will be 50 degree superiorly, 60 degree nasally, 70 degree inferiorly and 90 degree temporally. So these are the boundaries that we are testing during a confrontation test. So confrontation test, we do it on the bedside. In a patient who is not able to, who is not mobile, who is bedridden, but still you want to do the visual field defects, to look for visual field defects, you do a confrontation test. But in those patients who we have the ease of transporting to the OPD to do a perimetry, we go for the perimetry. So what are the visual field defects that we are looking for in glaucoma? That is, these are the standards. These are not specifically what you see in the perimetry only. This is the classically defined descriptions of visual field defects in glaucoma. So the first is paracentral, which is within 10 degrees of fixation. Moving on to the visual field defects in glaucoma. These are the visual field defects that are classically defined in glaucoma, and these are not necessarily what you see in the perimetry, but you can see phases of it in the perimetry. Okay, so this right here is the central scotoma, and this one just beside it is a centrocecal scotoma. Okay, so a paracentral scotoma is seen within 10 degrees of fixation. So that 10 degrees will be this line exactly here. So anything within that, you call that as a paracentral scotoma. So what is a cedal scotoma? You see, this is the blind spot. Okay, this black region here, this is the blind spot. Okay, so anything that involves the paracentral scotoma, that is the central 10 degrees and your blind spot, is called as a cedal scotoma. Okay, so what is Rowan's nasal step? You see this small gray area at the periphery that is there. That is the Rowan's nasal step. Okay, this is because of nerve fiber loss that happens asymmetrically. This is one of the earliest changes in glaucoma. Okay. Then comes the arcuate or germ scotoma. I told you about cedal scotoma, right? What is cedal? Paracentral with a blind spot. So this is the cedal scotoma. So this cedal scotoma, when it extends either superiorly or inferiorly, only one of that, you call it as germ scotoma. And if the same thing is there both superiorly and inferiorly, you call it a double arcuate scotoma. Okay. What is tubular vision? Tubular vision is the last thing that is the end stage of glaucoma, let's put it that way. So only this central field of vision is available. Okay. Moving on. So types of perimetry. There are two types of perimetry. All of this I am sure that you already know, but let's just go through it once. So there is kinetic perimetry and then there is static perimetry. In kinetic perimetry, we assess the hill of vision along the XY axis. This is where you see isopters. Okay. In static perimetry, you assess the hill of vision. This is your hill of vision. It's seen under the Z axis. Okay. So you see, Traquair actually described this as a hill of vision in a sea of darkness. So that is something that has been described for visual field since ages. Okay. So types of perimetry. When we talk about kinetic perimetry, we have confrontation tests, the one that I said that we do in the bedside. Then we have the tangent screen, we have the Lister's perimetry, we have campimetry and Goldman's perimetry. And in static, we have Humphrey, Octopus and Oculus. So Humphrey's field analyzer is what we use right now. Okay, so what is static perimetry? What is the aim of static perimetry? See, the aim is to find out the threshold of retina at various fixed points. These points will be prefixed and you are just going to record the stimulus in each point. So, the patient looks at a small fixation point which is located at the center of a white hemispherical ball, and light stimuli are presented at fixed stationary locations for a time of about 200 milliseconds. And the size of the stimulus, your background illumination, all of this is going to remain constant throughout the examination, however long it is. We will talk about the timings of the examination in the future slides. So, the light intensity is varied to define the minimum intensity necessary for the detection of a stimulus. Like say, the patient is not able to see properly. Consider it even as cataract. Patient has a cataract. The dull stimuli are not seen by the patient. So, progressively brighter stimuli will be presented to the patient to detect at what stage or at what intensity of the stimulus the patient is able to detect it. That is exactly what we are measuring in a static perimetry. So, there is a manual static perimetry and an automated perimetry. Automated perimetry is more sensitive and the results are more reproducible. They have quantitative information and more timing is better. You do not need an experienced perimetrist for this, and with newer perimetric tests, early detection of glaucoma test changes are also possible. So, this is actually how we do a perimetry. This is how the screen looks. Forgive the quality of the image, I was not able to get a better image, but yes, we talk the name of the patient, the age, gender, everything will be entered. Actually, exact date of birth is better, like instead of 60 years, a random date comes up, but it's better if you have the exact date. Again, I'll be talking about the importance of patient details and each and everything that has been mentioned here, and how it affects your results. Okay, so you enter your refractive error, you select what kind of test you want, and then what testing strategy is to be used, and then what stimulus color, size of the stimulus, and all of that. Okay. So this is how a patient is positioned in front of the perimetry. These are the trial lenses here. This is the background white illumination which is set at 31.5 decibels, 31.5 apostolbits. Okay. And we have to make sure that the trial lens are aligned with the patient's eye. Okay. So actually the first thing after entry of all the data, choosing the type of test that you want to do, what fields you want to do, central 30-2 or 24-2, we will be moving on to measuring the foveal threshold. Okay. In this, the patient will be asked to look at a central diamond of 4 lights, and then whenever the patient sees a stimulus, they will have to press the button that they have been given. This will measure your foveal threshold. Okay. Then the second thing that they do is gaze initialization. This is to make sure the fixation is proper. Okay. The patient has to try as much as possible not to blink, and this will make sure that the fixation target is perfect. These are the standard settings that are made in almost all the perimetries. The standard size is Goldman size 3. Only when there is a macular disorder where the patient cannot see the size 3 stimulus, you use a size 5 stimulus. The background illumination is 31.5. Okay. The maximum light intensity that can be projected by the Humphreys is 10,000 ASB and the minimum is 1 ASB. Okay. The testing strategy will be Sita standard. Okay. I've told testing strategies for quite some time now. So, we will see what the testing strategies are. Okay. So, now we will move on to the threshold test strategies. There were old standard threshold strategies which involved full threshold strategies. These took a lot of time and the patient was not able to concentrate for such a long time. So, they developed newer threshold strategies. Okay. There is fast pack, there is Sita standard and then Sita fast. There is something called a Sita faster also. Okay. So, what is Sita? It's the Swedish interactive threshold algorithm. It uses an artificial intelligence to give faster test results with the same accuracy. Okay. It will correlate well with the full threshold strategies also, and the speed of the stimulus is provided based upon the patient response also. There is not a standard speed of the stimulus. The machine will recognize the speed at which the patient is able to recognize the stimulus and then present accordingly. It does not calculate short-term fluctuations. So, the Sita standard will take 7 minutes per eye, Sita fast will take 4 minutes per eye, and see the faster will take 2 minutes per eye. I keep talking about something called as a threshold. So by this time you should be curious as to what a threshold means, right? So a threshold is the minimum brightness in which the brightness has a 50% probability of being seen. So what that means is, you present a stimulus to a patient, like say you present a stimulus at 1000 ASB to the patient, okay. You present it 100 times, and at 50 times if the patient is able to recognize that stimulus, then that is called as the threshold. Okay. If a patient is able to recognize it for more than 90% of the time, then it is called supra-threshold, and if it is less than 15% of the time, it is called as sub-threshold. So how is this threshold calculated? Okay. For example, you consider that they are giving this is the first stimulus that is given to the patient. Say it is taken as 40 decibels. Okay. So you reduce it by, you see if the patient is able to see this stimulus. Say the patient is able to see this stimulus. Then you reduce it by 4 decibel. What is that? 36. You use 36 decibel to see if the patient recognizes that. Okay. Patient is able to recognize that stimulus also. Now what do? You step it down even further. Now at 32 decibels, the patient is not able to see this stimulus. So what do? You increase it by 2 decibels to see if the patient sees it. Okay. Even now the patient is not able to see it, and another 2 decibel the patient is able to recognize this stimulus. So what exactly are we trying to do here? We are trying to pinpoint the exact intensity at which the light goes from, the intensity goes from a non-seeing point to a seeing point. So since it is 2 decibel, okay, say this is 34, okay, and this is 32. So where exactly do you think the threshold is? The threshold will be at 33, right? Does that make sense? Okay. So here the crossover is done 2 times, one from the seen zone to the unseen zone, and then back from the unseen zone to the seen zone. So here is the seen zone, here is the unseen zone, okay. You increase it little by little, and you see that this is the unseen zone, and you are moving back to the seen zone. And the middle area right here is the point where your threshold lies. Now newer testing strategies like FastPack and all use the 3 decibel testing system, where instead of this 4 decibel and 2 crossovers happening along the threshold line, there will be only one crossover happening when it is 3 decibel threshold. Okay. Now in a few areas I mentioned ASB, in other areas I have mentioned decibels. So how exactly are you converting this? Okay. So apostolepse is the unit of light intensity, but in perimetry it is fully represented as decibels. Anybody who has seen a perimetry will know this. Okay. So how do you convert ASB into decibel? So 1 decibel is equal to 1/10th log unit of attenuation of maximum available stimulus. So 0 decibel is equal to 10,000 ASB, 10 decibel is equal to 1000 ASB, 20 decibel is equal to 100 ASB, and so on, until 50 decibel is equal to 0.1 ASB. This area, if you remember what I said, this point is the minimum stimulus that can be recognized by a, that can be projected by a Humphreys, and this is the maximum intensity that can be provided by a Humphreys. If you see that there is an inverse relationship. What do I mean by that? Your decibel is directly proportional to retinal sensitivity. That means if the patient, I'll show this slide again, okay. So 10,000 ASB is the maximum stimulus. So if a patient is able to see a stimulus only at the maximum light intensity, then that means the retinal sensitivity is low, right? And if the patient is able to see at the minimum intensity, the dimmest light, if a patient is able to see, that means that their retinal sensitivity is high. So when you say 10,000 ASB in the perimetry, you mean that the sensitivity is bad. But when you say 0 decibel, that also means the sensitivity is bad. Please do not get confused between ASB and decibel. My advice is to remember the decibel part of it, because it's easier. See, 0 is bad. So that means patient cannot detect even the brightest stimulus. Retinal sensitivity is bad. 40 is higher, the higher the better. So you see 40, anywhere over 30, you decide ki the retinal sensitivity is good. Okay, so that is what I am trying to say here. Decibel is directly proportional to retinal sensitivity. The lower the decibels, the worse the retinal sensitivity. The higher the decibels, the better the retinal sensitivity. And ASB is inversely proportional to the retinal sensitivity. Okay. Once you get this concept clear, everything will start to make sense in your perimetry. It won't be just be a bunch of numbers, you'll be able to figure out what exactly they mean. Let's talk about classification of the Humphrey visual field tests. Okay, lot of this will be very familiar to you because you yourself would have ordered these tests for your patient. Central 30-2, Central 24-2, Central 10-2, the macular program and all of that. And then come your peripheral tests, the peripheral 60-4, the nasal step and the temporal crescent. These you would not have really ordered for any of your patients. And then come your specialty tests, the neurological 20 and the neurological 30. What I am going to be talking about is these. It is very imperative that you know why to order these tests, when to order them, how to interpret them and all of that. Okay, so these are your threshold tests. So the 30-2 perimetry. We keep saying 30-2, but do we exactly know what it means? Okay, so here we go. Here we are testing the central 30 degrees of your retina with the fixation point as the center. So this right here is your fixation point. This third circle is the 30 degree around the fixation point. Okay, so what is this point right here? Yeah, so this point is your blind spot. Okay, so this is your fixation area, this is your blind spot. So if this is the fixation area, what will it represent? Any idea? Yes, it will be your fovea, right? Okay, so this is the fovea, this is your blind spot and this is the 30 degrees of the retina with the fixation point at the center. Okay, fine. So each of these circles will represent 10 degrees. This is 10 degrees, this circle is 10 degrees, this circle is 20 degrees and this circle is at 30 degrees. Okay, if you note, there are no points on the axis, right? Okay, and the distance between 2 points is 6 degrees. Okay, total of 76 points are there. Just note the central 4 points, right? The distance between each of these points and the axis is actually 3 degrees. This area where there are no points, this area is called as the bare area. Okay. So what if there is a 30-2, then there should be something called as a 30-1 also. This is something that almost all of your examiners will ask you, and it's better that you know what exactly we do 30-2 for, right? In 30-2, if you see, there are no points on the axis, but in 30-1, you can see there are points lying on the axis also. So why should we prefer 30-2 over 30-1 in glaucoma? In glaucoma, this is something that you should know the difference between the glaucomatous change and the neurological change. In glaucoma will respect your horizontal meridian. All your changes are along the horizontal meridian. You will never see a change that crosses the vertical meridian. But in neurological defects, the neurological defects will respect your vertical meridian. How so? You know how bitemporal hemianopia occurs? It occurs like this. You don't see a bitemporal hemianopia looking like this, right? You always see it in one quadrant, in one hemisphere, that is, it will respect your vertical axis. But in glaucoma, you will see, for example, consider an arcuate scotoma. It's going to look something like this, right? You won't see an arcuate scotoma that is respecting your vertical meridian. Okay, so that is what I am saying here. Now, how do we convert a 30-2 to 24-2? It's actually not that different. Okay, so the central 24 degrees of the retina are taken in 24-2. That is, the edge point in the 30-2 are eliminated except for these two. Okay, these two lie at 27 degrees Okay, so technically you should call this a 27-2, but since all the other points are there in 24 degrees, you call it a 24-2. So these two nasal points are alone, lying on either side of the horizontal axis. Okay, so these are going to be at 27 degrees. Other than that, the rest of the edge points are taken off. So this is how you convert a 30-2 to a 24-2. Okay, there are 54 points in this. So in 30-2, if you saw, there were 76 points. Right? So this should have 54 points. Okay. Then there is the nasal step point pattern. This will explore your peripheral 30 to 50 degrees. This is used only in early glaucoma. Okay, here if you see, there are 2 points above and below the horizontal axis at 30 degrees, 40 degrees and 50 degrees, and 2 eccentric central points. A total of just 14 points are there. It detects early glaucomatous changes. Okay. Then coming to the 10-2. The 10-2, as you have figured it by now, it measures only your central 10 degrees. The difference here is the point to point distance here is 2 degrees. So that means you are measuring the retinal intensity closer. Each subsequent point is, each consecutive point is closer to each other. Okay. If you remember in 30-2, the difference was 6 degrees, which between each of your points, it was 6 degrees. So now from 6, it has been reduced to 2. So imagine how much intensity of your defects you can recognize by this. And in the bare area, remember what I said the bare area was? The 4 points right near the axis, 1 in each quadrant. This area is your bare area. In the bare area, the distance is barely 1 degree. Okay, in there it was 3 degrees. Okay, from 6 degrees between rest of the points, it has reduced to 2 degrees, okay, point to point distance, and the bare area, the amount has decreased to 1 degree. So this part is only 1 degree. Okay, this part is only 1 degree. Okay. And then comes the macular point pattern. This is going to be even smaller, right? The outer set, 3 sets of points are going to be eliminated. All of this is going to go away. Right, and only the central 3 degrees are taken, and about 16 points are only there in this, and the size stimulus is 5. Okay. If you see in this, there are 68 points, which is more than your 24-2 pattern. It's going to have 54 points. This is going to have 68 points, measuring your central vision in advanced glaucoma cases. Okay. So how to select which point pattern to do? This is very important for you clinically. You should know this in order to get better results. Okay. So in a suspicious case of glaucoma, you know how we diagnose people as glaucoma suspects, where there are disc changes, IOP is high, all of that. You immediately take a perimetry. At that time, you do a central 30-2 or a 24-2. In an established case of glaucoma, you do a 24-2. In advanced glaucoma, you do a 10-2 or a macular point pattern. In follow-up cases, this is important, please note this down, you decide based on your previous test ka parameters. So what exactly do you mean by this? You do a 24-2 on the first visit of the patient. The next visit, whenever that is, 3 months, 6 months, whenever the next visit of the patient is, do the same point pattern. Okay. And if it is 30-2, it's okay. You can still do 24-2 because you are just constricting the fields in a 24-2 when you compare to the 30-2. Okay, the testing strategy will be Sita standard or full threshold. If the patient is unable to concentrate for a long time, then you go for a Sita fast or a fast pack. So this is how your perimetry is going to look. Okay. They are dividing the perimetry into 10 different zones. Each of those zones have their own significance, why we should know about them, and we'll get into it. Okay. The first zone is the patient data. That is what you see here. This area right here is your patient zone. What does the patient data have? It has the name of the patient, the date of birth. Again, remember the exact date of birth is always better. Okay. You have what kind of testing strategy it is. We talked about testing strategies just before this. Okay. and then where is the fixation point, what is the fixation target, what is the size of the stimulus, background illumination, what strategy you are using, pupil diameter, everything, all of this information is there in zone 1, and all of these is equally important. Okay. Why is zone 1 important? That is, why is patient data important? We talked about the name of the patient. It is important for recognition, and you don't want to confuse different patients and their data and their results. Okay. When coming to age, age is very important because you want to compare your patient's data to the normative data of a person of the same age and gender without the glaucoma. Okay. So, second thing is your fixation target. See this one right here, right? This is your central fixation target. This is the standard fixation target that is given to a patient. This place will actually be illuminated. Okay. Then comes your small diamond. That is what has been illuminated in this picture. Okay. This is used in macular degenerations, and then there is a larger diamond also. Okay. When the patient can't see the small diamond, you use a larger diamond, and then there is an inferior fixation point also. You had seen in this that there was pupil size, pupil diameter, and your visual acuity and your correction, right? So, pupil size should be 3 to 4 millimeter. Okay. If there is a constricted pupil, it will give very diffuse visual field depression or edge scotomas. And if the pupil is less than 2 millimeter, then we should dilate before conducting the test. So, if the patient is completely dilated, you've dilated your patient, you see disc changes, you want to do a perimetry. So, can you do a perimetry in a dilated patient? If you are thinking no, that answer is wrong, because it is not an absolute contraindication. You can actually do a perimetry in a completely dilated patient with, let us say, 7 or 8 millimeter dilatation. You can still do that. Okay. But the problem is, this same diameter has to be mentioned for your future follow-ups, and that is not really ideal, right? So, that is why you usually avoid doing a perimetry after complete dilatation, but there is no absolute contraindication. So, if there is the necessity, you can still go ahead with the 7 millimeter dilatation, just that during the follow-up the same dilatation should be maintained. Okay. And then of course, refractive error. So, the refractive error must always be corrected, if not there will be a generalized depression or scotoma. Okay. For example, you have a patient who comes with a best corrected visual acuity of say 6.6. Best corrected visual acuity is excellent, okay, but your foveal threshold is only, which was measured at the beginning. You remember I told you we measured the foveal threshold? Yeah. So, if the foveal threshold is reduced, normally foveal threshold will be somewhere around 36 decibels, okay. If this number is reduced, it is only 28, then something is wrong. So, the first thing you have to look is the refractive error, and then check if the patient is not properly focusing. Okay, all of that you have to do. So, that is why your refractive error correction is very, very important. Never neglect it. Okay. Moving on to your reliability indices. So, these are the first things after patient data that you will be checking in a patient before you start interpreting your perimetry. This is something that we are all happy to see, right? Because the rest of the perimetry we don't have to interpret only. We can just say like, okay, not reliable, we will repeat the test next time. Yeah. Okay, we will see what these mean. Okay. So, fixation losses more than 20%. Okay. How do they check fixation losses? Before the perimetry and during the perimetry. Okay, say this is your perimetry screen, this is where your fixation point is, okay, and this is where your blind spot is. All of this is hypothetical. Okay, this is where your fixation point is, this is where your blind spot is. Okay. This is your blind spot and your fixation target. Okay. So, when the eye is fixing here and the stimulus is shown here, do you think the patient will be able to see it? No, right. So, during the test, during the stimulation, let us say around 100 stimuli they are giving during the entire test. Okay. During that, about 5% of the stimuli will be presented at the blind spot itself. Okay. So, if the patient recognizes those stimuli, then that means patient is not fixing here. Because if the patient was actually fixing here, patient should not be able to see a stimulus that is presented at the blind spot. So, any time that a patient responds, that is clicks when the stimuli is presented to the blind spot, then that means there is a fixation loss. Okay. So, if there are more than 20% of fixation losses, then the entire perimetry is unreliable. Okay. Second thing is false positive. False positive, if there are more than 30%, you call that as unreliable again. Okay. So, what is false positive? It's self-explanatory. Okay. So, what happens is, in your test, that is, patient keeps pressing the trigger, you call this a trigger happy patient. Okay. The patient keeps pressing the remote even when he is not able to see any stimuli. That means, imagine a patient is not able to see it, but still he keeps pressing it. Actually, if you people have undergone a perimetry yourself at some point, you will involuntarily find yourself being a false positive, high false positive patient, because when the stimuli are presented, there is actually an accompanying sound in the perimetry that you can hear. After some time, you will automatically start pressing the remote even when you hear the sound, even when you don't see the light. Okay. So, this is something that also causes the false positive. We call that a trigger happy patient. Okay. In this, even though a patient has glaucoma test changes, it will look like it is completely normal, and that is something that you don't want happening, right? Okay. Second is false negative more than 20%. False negative, what is false negative? When patient is able to see the stimulus, but he is not responding. This happens either because patient is not attentive, patient is tired, or just plain disinterested. Okay. So, the best way to do this test in case of glaucoma suspects or in follow-up cases is to get all of these three, all three to 0. That is the best, that is the ideal situation. I agree that that doesn't happen all of the time, but ideally this is what we want. Okay. Moving on to zone 3. Zone 3 is your raw data. This will give the exact retinal sensitivity in decibels. Okay. Like I told you before, 0 decibel will indicate absolute scotoma. Even at the brightest light intensity that is possible, patient is not able to detect your stimulus. So, 0 indicates an absolute scotoma and 40 is your highest retinal sensitivity. So, all of these are different points of the retina, and like for example, in this point the retinal sensitivity is 33, at this point retinal sensitivity is 29. These are the exact values, there is no change in these. Okay. This same value is converted into grayscale. So, the grayscale is actually important because it gives a diagnostic, gives a gross idea of what is happening, what to expect in this patient, and the grayscale is always easier to explain to the patient. Okay. You can't show numbers to the patient and expect them to understand. So, this one is like easier to explain to the patient, that is why we use this, and this is the conversion. Okay. So, one, to find the pattern of field effect. Second thing, like you look in this, if you see this, you know that it is an arcuate scotoma, that you can expect an arcuate scotoma, right? Okay. So, in this you see these areas, multiple white scotomas, yeah, these areas, these are all because of a high false positive. That means a trigger happy patient. You see something like this, you immediately realize that it's not okay. Okay. So, zone 5 is your total deviation numerical plot. So, this is your raw data. This is the first thing that you see on your perimetry, and this is the total deviation numerical plot. So, what exactly is it? I told that all your data, all your patient's data will be compared with the normative for the age and gender, right? So, that is what they are doing. They will subtract it from your raw data to give your total deviation numerical plot. Okay. So, if this is 21 and this is -6, that means the retinal sensitivity of your patient has reduced by -6 decibel, okay, compared to the normal. That means obviously it is abnormal, right? So, consider this point. This point when you compare with the normal, it is only 0. That means patient sensitivity is as good as the normal. Okay. Here it is 31, right? Here it is 1. That means your patient sensitivity is better than what is considered as normal, which is a good thing. Okay. And then you convert it into a probability plot, that is your zone 6. Okay, so the total deviation numerical plot is converted to the total deviation probability plot. How do they do it is by this graph, right? So in p less than 5%, it indicates that this degree of loss of sensitivity at that point is seen in less than 5% of the normal population. That means this kind of change is normal only in the 5% of the population. And then p less than 2, this change is normal only in less than 2% of the population. P less than 1 in less than 1% of the population. So progressively it gets worse. Then you talk about the pattern deviation numerical plot. Okay, so why do we make this pattern deviation plot? This total deviation plot that we were talking about here, right? This is going to talk about a generalized field defect, that is whatever is caused due to uncorrected refractive error, due to glaucoma, all of that is going to be manifested in your total deviation plot. So to know the pattern, extent and the depth of your scotomas, this depth of your scotomas, you have to do a pattern deviation numerical plot. Whatever is masked by your cataract, underneath the cataract is their glaucoma. That is what you will know by doing your pattern deviation numerical plot. Okay. So how is it calculated? First you select the 7th best sensitive point in the TDNP. Okay. You might have a question as to why 7th. It was just statistically determined by collecting tons of data. Okay. You don't have to bother with why that number, but yes. So the 3 points in the area of the blind spot are ignored. In 30-2, only the 24-2 points are taken, and in 10-2, all 68 points are taken. So how do you take the 7th best sensitive point? Okay, you take all the values in this plot. Okay, take all the values in the plot, okay, that I talked about, and arrange it in ascending order. Okay, and in that order, whichever is the 7th point will be your 7th best sensitive. If you see here, like see, -3, -2, okay, -3, -4, 1, 2, 3, 4, 5. I mean, these numbers are arranged in the ascending order. If you see, -6 is the 7th sensitive point, 7th point in the order. So that point you are going to convert it to 0. So if you have to convert this -6 to 0, you have to add +6 to it, right? So each of these points you add +6 to it. So -4 + 6 is 2, -3 + 6 is 3, -5 + 6 is 1. You are adding, you are making sure that this point becomes 0. Okay, that is what you do in the pattern deviation. This 7th point is neither too less or too much. What do I mean by that? That is, it is not too much as in it won't mask a glaucomatous change. Okay, it is not going to reduce the glaucomatous change. Okay, so zone 8 is the pattern deviation probability plot. The probability plot is calculated the same way that the total deviation probability plot also was calculated. The same p less than 5, p less than 2, p less than 1 and p less than 0.5. The same graph applies here also. Okay. So if you see here, this was the total deviation probability plot. You should see that almost all points are p less than 0.5%. If you just look at this total deviation probability plot, you will definitely think this patient is a case of advanced glaucoma, right? But when you see this pattern deviation probability plot, you see almost half of the points have become p less than 5% or even lower. See, only a couple of points are p less than 5%, right? Others are all lower, right? So this means that these extra points here have all been caused by a generalized field defect, most likely a cataract. And then only these points that you see in the pattern deviation probability plot have been caused by the glaucoma itself. Okay, this is an irregular generalized field defect. Okay, you see a uniform generalized field defect, meaning what? In this, the entire plot again looks like an advanced glaucoma. But when you see this, the pattern deviation plot, there is literally nothing in this. So that means there was never an evidence of glaucoma. There was only cataract in this patient, and this pattern deviation plot is absolutely normal. Okay. Moving on to your global indices. These are the one other thing that you definitely have to know. So there is mean deviation, there is pattern standard deviation, and then there is short-term fluctuation and the corrected pattern standard deviation. These two are actually not seen in your CETA standards. Okay, These two were there only in the full threshold. Okay. Now, right now in your Sita standard, you will have only your mean deviation, your pattern standard deviation. Okay. To understand mean deviation and pattern standard deviation, I am going to talk about the hill of vision. Like I said in the beginning, Traquair was the first person to coin this term, hill of vision in a sea of darkness, right? In this place, the highest point of retinal sensitivity will be where your fovea is. After that, the retinal sensitivity will fall towards your periphery. So, this is your hill of vision, right? So, this mean deviation will talk about how equally the loss of sensitivity is distributed, that is how much the height of the hill falls. So, this is what a normal hill height should be. Okay. There is a regular fall of the height of the hill in all points. Okay. This is what is measured by this distance between the original area and the fall in your patient is going to be measured as the mean deviation. That is the deviation from the normal. That is what we are measuring in mean deviation. Okay. So, for example, see here, a normal hill of vision is supposed to look like this. This shaded area is where your patient has a defect. So, this is the localized defect, right? Only here the hill of vision has fallen, but the rest of the height of the hill is normal. This is the uniform generalized field defect. That means the hill has fallen everywhere equally. In this, the MDI will be reduced. Okay. This is an irregular generalized field defect. Hill also has fallen in height. The type of fall is also very irregular. So, where do you see this? What do you measure when you want to measure how irregular the fall is? That is where your pattern standard deviation comes into play. That is going to measure how much the contour of the hill has changed throughout your test. Okay. Okay. So, where do we stand with mean deviation index in early glaucoma? Right. So, normally there should be 2 decibel difference between both the eyes, or a 1.5 decibel difference between 2 eyes on 2 consecutive tests. Like, to make it more clear, say the mean deviation index was minus 3 in the right eye, minus 4.5 in the left eye. Okay. This is the right eye, this is the left eye. Okay. In this, less than 2 decibel change is there. So, this is most likely not a glaucoma, right? That is what I have told in the first point. Okay. In 2 consecutive tests, okay, say in the second test also, this was in June 23, okay. You take the next thing in November 23. In November 23, if the same thing is followed, this 1.5 decibel difference is still maintained. This is still okay. If on the 4th test also, let us say it was 3 in the right eye and it has become minus 5.5 in the left eye. That is, the decibel difference is now minus 2.5. This is not okay. This is definitely, this is most likely a glaucoma change. So, any deviation from this is considered as a glaucoma change, right. So, 2 decibel between 2 eyes in a single test, 1.5 decibel difference between the eyes on 2 consecutive tests, and 1 decibel difference between 2 eyes on 4 consecutive tests. All of this will indicate a normal, and anything more than this is a glaucomatous change. Okay. The expected change in MD per year is 0.08 decibel, which is considered normal. Anything more than 0.08 decibel per year is considered as a glaucomatous change. Also, another thing that you should do is increase in the MD index should not be due to improper refractive error correction, pupil size, false negative, different point strategies and all of that. Okay. Moving on to the pattern standard deviation. So, here it measures the contour of the hill of vision. Like I said, all your irregular field defects will be better depicted through your pattern standard deviation. The best thing about mean deviation index and pattern standard deviation is you do not have to remember any of the values. If it is significant enough, it is going to come as p less than 0.05. So, as soon as you see that, you know that something is wrong. This is how a localized field defect will look. If you see here, the field defect is somewhere around here, right? The contour of the hill is rough. What is it? So 0 means what? Do you remember what I said when the total deviation numerical plot gives 0? That's actually good, right? The retinal sensitivity is the same as normal. But if you see here, it is minus 28, which is very high, right? So if you see here, this area known is bad. These rest of the areas are okay, right? There is 0, 3, some places that are better than the normal, some places that are a little lesser than normal, but still manageable. So this area corresponds to this area in the field effect. Okay. In such cases, the PSD will be high. In a uniform generalized field effect where everything falls, there is no change in, very little change in the inter value between two values, that is it's minus 8, minus 9, minus 7, it's all between the range of minus 6 to minus 11, which is a very small range, right? So in such cases the hill would have fallen uniformly. So there is a smooth contour of the hill, PSD will be low. In an irregular generalized field effect, PSD will again be high. There is both fall in height, there is also change in contour. Okay, I hope this makes sense to you. Every value is different, everything is all over the graph, right? So there PSD is high. So what is the role of PSD in follow-up tests? This is important, okay. There is an increase in MDI and PSD, that means in spite of the general depression, there is a localized area of depression also. If there is increase in MDI but no change in PSD, then it is only uniform generalized type. So what do I mean by this? If there is both MDI and PSD change, that means localized area meaning glaucoma, generalized depression meaning cataract. Okay, so there is definitely a glaucomatous change in comparison. But if there is no change in PSD, there is no localized effect, there is only cataract. So this is one important inference that you can take from your mean deviation index and your pattern standard deviation. Short-term fluctuation is an intra-test variability. Okay, in this what they do is they will select 10 points. These are 10 pre-selected points at which your threshold sensitivity will be calculated twice. Remember how I told we will calculate the threshold sensitivity? The staircase method, right? The same threshold will be calculated twice at these 10 pre-selected points. Okay, and the threshold values at both these times will be taken and expressed as a root mean square. Okay, the normal is 1 to 2.5 decibels. It should not exceed 3 decibels. The only thing is it can indicate either a pathology or a reliability. Okay, and this is in our newer tests. Now most of us actually follow CETA standard, CETA fast or CETA fast pack. So in that it doesn't actually calculate the short-term fluctuation. Finally, your glaucoma hemifield testing. Okay. In glaucoma hemifield testing, we evaluate 5 zones in the upper field and compare them with the 5 zones, mirror zones in the lower field. Okay, what exactly is this? This is your blind spot again. I will keep reiterating it throughout so that you form a clear picture in your mind. Okay, so this is your fixation point. Okay, so how exactly is this? Doesn't this kind of look like your fundus diagram? This is your optic disc. This right here is your optic disc, right? This is your macula. Okay, this is your papillomacular bundle, right? These are your arcuate fibers. Makes sense? So this this glaucoma hemifield testing is designed in such a way to approximate in the particular patterns of your retinal nerve fibers. Okay, and the difference between this upper zone areas and the lower zone areas are compared and calculated. Okay, so these 4 points are these 3 points are compared with these 3 points. Wait, I'll show you. This is 1, 2, 3. These are corresponding to these areas. So this will be 1. This will be 2. Right? This is the mirror image. Okay, this area will be 3. Okay, this area will be 4. I am not drawing the exact same diagram, but you get the point, right? So this area will be 5. The same mirror images will be calculated on both hemispheres, upper and the lower hemispheres. Right? And the difference between them is taken. So this will give you 5 possible results. One is outside normal limits. This is what is the most important in glaucoma. When does the perimetry declare that it is outside normal limits? If one of these 2 conditions are met. What are the conditions? you compare between the two zones, at least one sector pair score difference must exceed than that found in 99% of the normal. Okay, I'll show you an example. Okay, this is a normal limits GHT. Okay, GHT within normal limits. These are the two corresponding zones. These both are the first zone, right? You see this, the values are almost the same. The difference is very little. This kind of difference is actually normal. Okay, say this was minus 23. Okay, consider that this point was 23. Then that means this difference is what? 23 and minus 3 becomes almost 21. 21 is the difference. This difference is found in, is not found in almost 99% of the normal people. That is what they say. So such a difference it is there between two zones. Here I talked only about one zone, right? Consider that something happened in this zone also. When something like that happens, then GHT will come as outside normal limits. Or if individual zone scores in any zone pair exceeds that in 99.5% of the individuals, that also is called as outside normal limits. Borderline, this 99% just becomes 97%. Okay, that is when you call it borderline. Generalized reduction of sensitivity is when none of these conditions are fulfilled. Okay, all these three conditions are not fulfilled. Okay, but the general height, what do I mean by general height? The hill of vision. Okay, what we talked about, the mean deviation index and all of that, right? So that general height calculation shows that the best part of the field is depressed to a degree that occurs in fewer than 0.5% of the normal. Okay, when such a thing occurs, then you call it as a generalized reduction in sensitivity. Abnormal high sensitivity means it is better. It is better than the rest of the people. This abnormal high sensitivity is of some significance. We will get to it. Okay. And then there is normal limits. When none of the above four conditions are met, you call it normal limits. So this is a normal limits GHT. Right? Almost all values, all mirror values are similar to each other, right? Minus 3, minus 1, here it is 1 and 0, right? In high false positive errors, what did I say? Multiple white scotomas. If you look at this gray scale, when I say multiple white scotomas, I mean the gray scale. If you look at the gray scale, there is so many white areas, right? And if you look at GHT, you will see abnormal high sensitivity. So that means this is better than most patients. This is not possible, right? And if you see here, your false positive errors, 57%. Okay, this is the proper definition of a trigger happy patient. Okay, 57% of the time patient has been just clicking the button. Okay, so this is abnormal high sensitivity. And first itself we have written low patient reliability. Okay, then false negative errors. So this is one question that all examiners ask. Clover leaf shaped defect. This is seen in your high false negative error patients. GHT will be outside limits, your total deviation plot and your pattern deviation plot will look horrible. So that is why they say the first thing that you should look at is your false negative, false positive, all of these errors should be looked at first. Okay, then only you move on to the rest of the fields. So in such a case, why does this clover leaf pattern happen? Do you have any idea? I told you that false negative errors happen in where patient is not attentive, patient is tired, they are not interested, all of that. So in the beginning of the test, patient is interested. They are finding it okay, I am doing well and all of that. After the initial 2 minutes, they get tired of it. They are like, how long can I keep fixating on the same point? This is getting very tiring. They start to lose focus. So in the beginning stages, it is good. As the test progresses, patient is becoming unattentive or sleeps off and they don't press the button anymore. That is why this clover leaf pattern happens. Okay. And then come your rim artifacts. You remember when I told you the lens have to be placed correctly, the correction lenses have to be placed exactly in the right position in the perimetry before the beginning of the test. So this image was of the gray scale. Okay. But on seeing this, our consultant felt something was wrong. This cannot be the field defect of the patient. And when they asked to adjust the lenses again, this was the field of the same patient. So you see how the difference makes. So how do you avoid errors like this? on first glance, you would feel like something is horribly wrong, right? Unless you know that something called as a rim artifact exists. So how do you, otherwise, if you don't know, what do? Always compare your fundus, your clinical picture, with your perimetry changes. Just reading a perimetry is not enough. It should always correlate with the actual disc findings that you see in your patient. Perimetry alone is not going to help you diagnose glaucoma. This is a mantra that you should keep telling yourself. It should correlate, right? So when do you call a perimetry as a glaucomatous change? You diagnose it using your Anderson's criteria. So there are 3 criteria. Okay, this is a mistake that even I made when I was initially diagnosing glaucoma and perimetry. We always used to consider these black points, right? We used to say, okay, there are a lot of black points on the, the perimetry result, so that means it's glaucomatous. Actually not. Even P less than 5% is considered as glaucomatous, right? This 4 dot, even that is dangerous, okay? So how do you diagnose that? You use a minimum of 3 non-H points. This we keep hearing, okay, non-H points, meaning in a 30-2, please remember that, in a 30-2, 3 non-H points, okay, that is all these points are all not considered, okay, forget all of these points, okay, non-H points are not considered, okay, and in those 3 points, 2 should have a value less than 5% and 1 point should have a value less than 1%. That means if you see these 2 symbols only, you can call it a glaucomatous change. It doesn't have to be P less than 0.5. It doesn't have to be completely black. Okay. So the second criteria is PSD P less than 5%. And then criteria 3 is your GHD is abnormal. So all these 3 comprise Anderson's criteria. Please remember, not 0.5, P less than 5 in 2 points and P less than 1 in 1 points and 3 non-edge points. So that means in 24-2, do we consider the edge points? Yes, because you just remove the edge points in a 30-2, you get a 24-2. So in 30-2, you don't consider the edge points. So that is why this 3 non-edge points is applicable only for 30-2. In 24-2, you consider the edge points also. Okay. So criteria for early defect. Just remember this, -6 decibels, okay. And in 25, that is the mean deviation index is better than -6. That is from -6 decibels to -12 decibel. Any value between this, you call it as an early defect, okay. And 25% of the points should have P less than 5% and less than 10 points have a P value less than 1%. And there is no point in the central 5 degrees with less than 15 decibel. This is in your total deviation plot or the raw data. You see that nothing should have a sensitivity less than 15 decibels. If, like I told you, 0 means bad, 40 means good. That means 15 is more towards 0 than 40, right? So that means it's bad. Okay, so in the central area, in the macular area, you're supposed to have the highest sensitivity, right? That is what your hill of vision suggests. This is what your hill of vision looks like. Okay, that's a very bad diagram, but this is what the hill of vision looks like. This is supposed to be at 36, right? Where is 36 and where is 15? Right. So anything in the central 5 degrees that is less than 15 decibels, you call it an early defect. When do you call it a moderate defect? If it fulfills more than one criteria in this. Either your mean deviation index is gone or your central 5 degrees is involved, or your 25% of the points in TD and P have P less than 5%. So any of these 2 are fulfilled, it's a moderate defect. So what is severe defect? Anything worse than -12 decibels in the mean deviation index, and more than 50% of the points have P less than 5%, and more than 20 points have a P value of 1%, and of course the central 5 degrees will be involved. Okay, so let's interpret this one. Okay. First, I've blocked out the patient data. Okay. Your fixation monitor blind spot is on, your fixation target is central, there are 0 fixation losses, which is very good. False positive errors is 2%, which is good. False negative is 0%. So that means, first thing, reliable. Foveal reflex also is good. Foveal threshold is also good. 34 decibels. All of this is done. Okay. Stimulus is size 3, background illumination. You are evaluating a Sarita standard, 24-2 threshold, right? Correction has been given, age has been entered, everything done. All okay in the top part, in zone 1. You look at the grayscale, on the surface it looks normal. You look at the raw data, everything is good, more than 28, 29, 30, okay, right. You look at the total deviation plot next, right, there is nothing. You look at the probability plot also, there are barely 2 points that are p less than 5%, nothing p less than 1%. Same here also, pattern deviation plot also seems absolutely fine. Then you look at the GHT within normal limits, you look at the mean deviation index, all okay, right. So this is a normal patient. In a glaucoma suspect, you see something like this, you should be happy, there is no glaucoma, okay. Now moving on, I am going to show you cases of glaucoma with both field defects and perimetric changes. Consider that all the patient data has been entered, the data is reliable, okay. We will just be interpreting or comparing these with each other, okay. So what you see in this CDR of 0.8, right, there is inferior notching, okay. Just remember, okay, you see inferior notching here, you will get a superior scotoma in the patient, okay. Please don't confuse between, don't say that it's inferior here, it's superior here, it doesn't correlate, no, it's inferior there, you get a superior scotoma, okay. If you see this, Anderson's criteria is fulfilled, right, right, there are 3 non-edge points right here, 1, 2, 3, right, and then GHT is outside normal limits, MD is still bad, okay. The second thing, there is an inferior RNFL defect. This is actually very obvious. You can see that huge defect there, right. So this RNFL defect will lead to a superior arcuate scotoma. Again, 3 non-edge points, all okay. GHT, I mean all okay, I mean criteria, Anderson's criteria is fulfilled. GHT is outside normal limits. Mean deviation is p less than 5%, as I told you before, right, okay. Then in this there is a superior RNFL defect shown by arrow marks right here, okay, and you can see a inferior paracentral scotoma, right. Anderson's criteria again definitely fulfilled. GHT, second criteria done, third criteria mean deviation less than 5% done, right. Next, you can see inferior notching here, inferior RNFL defect here. Actually the RNFL defect is not that obvious as the previous pictures, but it's still there right here, right. And look at the pattern standard deviation, pattern deviation, full. Anderson's criteria definitely fulfilled. GHT outside normal limits, your mean deviation index p less than 0.5, not just less than 5, less than 0.5, okay. And then of course visual field index also is something that we look at, but the better indices are your mean deviation and your pattern standard deviation, right. Next, if you look at this, there is a superior arcuate scotoma involving almost the entire hemifield. GHT is outside normal limits, p less than 0.5, p less than 0.5 for both mean deviation and pattern standard deviation. Next, there is severe neuroretinal rim thinning, there is barely any rim, 0.9 cupping is there, right. And you see a corresponding very bad, you know, field defect in this. Pattern standard deviation, Anderson's criteria is fulfilled, outside normal limits, mean deviation p less than 0.5, p less than 0.5, right. And finally this one. This is, there is less than 10 degree of vision is remaining in the patient, barely anything is remaining, right. And then GHT outside normal limits, visual field is only, right, 26%, p less than 0.5, p less than 0.5, right. What is this? This is something that, this is a splinter hemorrhage called what? Drans hemorrhage. Drans hemorrhage is something that you see in a normotensive glaucoma patient, and it's not such a good sign to see. That means the patient has a probability of progressing to primary open angle glaucoma, okay. Okay, now diagnose this for me, okay. IOP is 28, okay. There is an inferior RNFL defect, as you can see right here, RNFL here, RNFL here, there is a wedge shape defect there, okay. It's actually more than a wedge shape, right. There is an inferior RNFL defect. You look at the perimetry, reliable, I mean, like I said, consider this reliable, Okay, no changes in the TDNP. There are few changes in the pattern standard deviation, but Anderson's criteria is not fulfilled. Why? Because criteria 1 is fulfilled. Agree? Right? Criteria 1 is fulfilled. But GHT is within normal limits, mean deviation is also normal. So that means this perimetry is normal perimetry. Nothing is wrong with this perimetry, not really. Okay. But you see an inferior RNFL defect, you see IOP is more than 28. Right? In such a case, this is called a case of preperimetric glaucoma. Right? This is a second case. Okay. This is the same patient this was in August 2013 and this picture is February 2018, right? You see this defect here, small defect here, entire RNFL only is lost. There is only one small fiber left here and one small fiber left here. Look at the amount of defect here, how much it has proceeded here, how much the cupping also has progressed. Okay. If you look at this, mean deviation is -7 here. It has gone to -11 here. So this much change is not allowed. This is too much change, right? Same thing in pattern standard deviation. That has also risen here. Both of it is P less than 0.5. This indicates progression. Okay. And actually if you see in this, there is a corresponding change in the field effect also. Look at how much it was here and how much it has progressed to in this. Right? Okay. If you see in this, there is NRR thinning, 0.9 cupping, biarcuate scotomas, not much of a difference between grayscale and your total deviation plot and your pattern deviations. Okay. Actually, in this there is no pattern deviation. They have not made it. There is only the total deviation. If you see that, the changes are very corresponding. Outside normal limits, mean deviation P less than 5%, all of that. This is another case scenario for you, right? A patient comes, you do a routine examination, you see that the IOP is 22, 24 on one visit. You do 3 consecutive measurements. It's 22, 24, 24, 26 and 24, 25 in the right and the left eye respectively. You do OCT, OCT is normal. You see the disc, okay, that's a 0.6 cupping, healthy NRR, nothing much to complain. You don't really think anything is wrong except for the 0.6 NRR. You do a perimetry just to be sure, right? You see that perimetry is also within normal limits. Why did you do all of this? Because your IOP was slightly raised. So this is probably a case of ocular hypertension. Okay. Actually, this will be an ideal place for you people to take a break in case this is becoming too much. Okay. If not, we will be moving to glaucoma progression analysis. So this is how a glaucoma progression analysis setting looks like. You have to specifically select it in the Humphreys visual field analysis. There is an option for it. You can go for it. This is how it looks like. Okay. The mean deviation, pattern standard deviation will be given. Your fixation losses, false negative, false positive will be given. Okay. The grayscale is there. The probability plots are there and the probability analysis is also here, right? Okay. So this was the perimetry of a patient in 2000, 2002 and 2004, 2-year gap. Okay. This is the grayscale image. Okay, look at the mean deviation. First thing you look here is it's not the first thing, okay, but here in this specific page you can see your mean deviation was -7, progressed to -11, progressed to -14. This is most likely a progression, right? This is what we were talking about, okay, because in a year it should be less than 0.08. That is definitely not the case here, okay. If you see this, you can see Anderson's criteria is fulfilled in almost in all 3 of them. Pattern standard deviation also is on the rise, right? Okay, here comes the important part. So this probability plot will tell you about possible progression and likely progression, and then this is your GPA. So if there is a deterioration from baseline at P less than 5, that comes as a triangle. and then deterioration at the same location in 2 consecutive tests, that comes as a half split triangle, and if the deterioration is at the same location for 3 consecutive tests, it comes as a fully shaded triangle, right? So how do you interpret the overdue printout for GPA? What is important, what is not? First is patient data, as usual. You don't want an identity crisis, right? So step 2, you always look at reliability indices before comparison. We'll get to why that is important. Third is check MD index and PSD. This is what we already talked about, right? When there is no change in PSD, it is probably a generalized depression. That is, the height of the hill is reduced, but contour of the hill has not changed, right? This is what change in MD but no change in PSD looks like in the hill of vision. If PSD has changes, meaning something, it looks like this, okay? So there is a localized defect right about here. So that means it is most likely to be glaucoma. Finally, you have to check the probability plots, okay? What is the effect of reliability in this? Okay, in this patient has a false negative of 9%. In this patient has a false negative of 1%. What is false negative? Patient can see the stimulus but is not responding to it. That is what we call as false negative. Am I right? So in this, if you see, Anderson's criteria is definitely fulfilled. Look at the number of scotomas that are there in this patient. But when the false negative was reduced to 1%, this is not such a bad change, right? Even you can't even say that the Anderson's criteria is fulfilled because edge points are all involved, right? So such a thing you can't call as glaucomatous change at all. So look at the magnitude of difference that is made. Even though this, with a false negative of 9%, this field is actually reliable. You can rely on it. But still, when you reduce the false negative, this patient barely has any glaucoma. Right? You will be starting a patient with such field effects on all anti-glaucomatous medication. You will be counseling them and all of that. And then the progression, when you do it at FN 1%, so much difference is there, right? So this is why false negative is important. So why is false positive important? Okay, this was a patient with 0 false positive. Okay, this was the first test that was done in the patient in say 2000. Okay, this was when false positive was 13%. Trigger happy patient. Again, look at how many areas have come out as almost normal. Okay, so this is, what would you think in such a case? In such a case, you would think, you would obviously not think that the glaucoma has become better, but in such a case you should repeat. You should repeat to make sure that the false positive is, like I said, ideally 0, but anywhere less than 5% should do the trick. Okay. Finally, this is one table that is easy for interpretation for MD index. There is nothing in this that we have not talked about. Okay. Increase in MD index means there is a progression of field defect. So once you say that there is a progression of field defect, you look at PSD. If there is no change in PSD, then that means it's only cataract. Okay, that is it. Let's cut through all of these. Okay, there is no point in it. So if you see PSD, there is change in PSD, there is irregular loss of sensitivity, then obviously glaucoma is associated with the cataract. Directly come here. Okay. If there is no change in MDI, no change in PSD, then there is no progression in glaucoma. That's it. Okay. Another thing that you should do is correlate between OCT and perimetry. If you look here, there is so much loss in this area, same corresponding area loss is there here also, thinning, everything is there here also. Thinning here and loss of field here, right? Yeah. Finally, a 10-2. When do you do a 10-2? A 10-2 is going to talk about your central 10 degrees, like I said. You do it only in advanced glaucoma or established glaucoma and when you suspect a macular split. This is going to be nothing much different about the depiction of the entire result except for the fact that this is only central 10 degrees and the number of points here are 68. Okay. What is macular split? Okay. So for macular split, there are actually 2 schools of thought. Okay. One school is that even if at any one point in these 4 areas, 1, 2, 3, 4, in this even in one point, if there is a zero sensitivity, a zero value in any one point of these four, you call that a macular split. Or this is the other one, single digit sensitivity, okay, with an adjacent point on the same side less than 10. Okay, for example, if this is 0, this is also 0, or if this is 5, this is somewhere around 3, something like that. If such a thing exists, then you should suspect a macular split. Okay, in this you see the 4 values, right around the axis, around the bare area, you see 3 zeros and 1 5, and this is what test is it? It's a 24-2 threshold test. So can you say that there is a macular split or a foveal split based on this information? What do you think? If you said yes, you are wrong, you can't. Okay, you have to always do a 10-2 when you see a split like this. So such a split is there, okay, in the central 4 area, you do a 10-2 and you see the value 16, 25, 24, 24, which is nowhere close to 0, right? So that is why you always have to do a 10-2 before you tell that there is a macular split. So in this patient, you see there were 2 zeros, 122, 1 8 and all of that. You do a 10-2, you see 1 0 here. Then that means that there is foveal split in this patient. Okay. So when you're talking about foveal split, actually even in a 10-2, the most important thing that you should consider is always look at the raw data. Okay. So what if there is a foveal split? There is a condition called snuff out or wipe out phenomenon that almost every glaucoma surgeon is afraid of, even though it occurs only in less than 1% of the individuals. Okay. So it is a severe unexplained vision loss after glaucoma filtration surgery. Suddenly immediate post-op patient will have some 6-18 vision or something like that, and then suddenly in a few days vision will go to hand movements. So this is called a snuff out phenomenon. Incidence is actually only 1%. The only risk factor for it identified is there is a pre-op foveal split in the 10-2 fields. Okay. Then moving on to your newer perimetry methods, that is frequency doubling tests, which is a compact, inexpensive perimeter whose transportability, tolerance to refractive errors and rapid test timings. It takes less than 1 minute per eye. Imagine how fast that would be. Okay. It is used for visual field screening. You can use it even on the field. And it determines the contrast sensitivity necessary for stimulus detection by itself. Next is the short wavelength automated perimetry. It is used to detect early glaucoma. In this, an intense yellow background is used. Normally, what background is used? White. What is the size of the stimulus? In normally, size 3 is used, right? And the stimulus is also white. Okay. But in this, there is an intense yellow background with blue light as the stimulus. Okay. This yellow background will bleach your red and green cones. Okay. That is why they use this, because at this yellow background only the blue cones are active. Okay. And this uses size 5 stimulus. These are the changes between your automated perimetry and your short wavelength automated perimetry. Then there is this newer addition, 24-2-C. In this 10 points, 10 points from the 10-2 are added to the 24-2. These are not symmetrical, but these are the most common points that are affected in glaucoma. Okay. Finally, microperimetry, right? Microperimetry is a visual field test that incorporates perimetry and retinal imaging also. Both will be displayed side by side for easier comparison. So it allows for the direct mapping of the stimulus in the region of interest, and you can correlate functional information, that is your visual field testing, with your anatomical information, which is your retinal imaging. This is a method of choice for residual visual functions assessment, and in this you can identify eccentric fixations known as preferred retinal loci rather than a central fixation. Okay. There is also atrophic and you can use it in atrophic and neovascular AMD, glaucoma, diabetic macular edema, CSR, HCQ maculopathy and macular hole, where central fixation is not possible. There is an eccentric loci of fixation. Okay. Moving on to the supra-threshold strategies, there is a 2-zone strategy, there is a 3-zone strategy, okay. There is quantified defect strategy and single intensify strategy. So the supra-threshold strategies. I explained what supra-threshold means. Okay, that means 100 times a point is presented and 90% of the time such a point is recognized, right? So supra-threshold strategies are used in to detect early glaucoma, right? So there is the 2-zone strategy, there is a 3-zone strategy, there are quantified defect strategy and single intensify strategy. I could go into this. So in 2-zone strategies, there are 4 paracentral points that are used to determine the threshold, and each stimulus will be 6 decibel brighter than the threshold, and each stimulus will be tested twice. Okay. In 3-zone, what happens is when a patient fails to respond to a supra-threshold, the maximum stimulus is then presented. Okay. You should remember that supra-threshold is more of a screening strategy rather than a diagnostic strategy, because supra-threshold doesn't have normative data for it. Okay, supra-threshold is just to give you a generalized idea whether you have to test the patient for glaucoma or not. Okay. So to summarize, how do you report a perimetry? First, confirm patient data including refractive errors, look at reliability indices, check for Anderson's criteria, check for global indices and GHT, and then during follow-up you are going to use glaucoma progression analysis, right? This is for early glaucoma or suspected glaucoma, or for confirmed glaucoma cases for follow-up. Then in advanced cases, you are doing 10-2, you look only at the raw data, you decide on foveal split with 10-2 only, remember not on 24-2, only on 10-2, and then counsel the patient pre-surgery accordingly if foveal split is present. So that is it. I have actually referred Shields' book of glaucoma, G.R. Reddy for perimetry, and Dr. Ramakrishnan's book for management of glaucoma, and picture courtesy. Almost all of the pictures I have taken from either G.R. Reddy or AIOS flip book for open angle glaucoma. So thank you so much.